Hello and welcome. Thank you so much for joining us today. I'll be our chair for our session. I'm really pleased to have you with us. Our session, as you've seen, is titled Digging into Urban Health, Uncovering Concepts and Action for Health and Social Justice in Informal Settlements. We're very lucky to have presenters from Sierra Leone, India, Uganda, Bangladesh, and I'll be discussing Kenya. I think at the beginning, it's probably best if we introduce all of ourselves. So I'll just ask, if possible, to put the cameras on for my fellow presenters, just so you'll know who we are. We're joined by Moyiba Cont'd, who is an Urban Health Research Officer at the Sierra Leone Urban Research Center, or SLURC, in Freetown, and he's also completing a PhD at the Liverpool School of Tropical Medicine. His interests include health systems research and social policy practice to improve health systems and accountability for the urban poor. Previously, he worked with Concern worldwide in Freetown's impoverished communities to improve maternal and child health care interventions, and to pilot community-based health information systems in collaboration with Johns Hopkins University. And we also have Sureka Garimella, who's a senior research fellow at the George Institute in India. She holds master's degrees in nutrition and food science, as well as applied economics, and a PhD in public health, gender, and work. Her interests include gender, women, work, and political economy, gendered health systems and accountability, and ethics of research practice. And we also have Sabina Rashid, who is Dean and Professor at Brack James P. Grant School of Public Health at Brack University in Dhaka. She has bachelor's and a master's degree in social anthropology and a PhD in medical anthropology and public health. She's joined the school in 2004 and was appointed Dean in 2013. Her specialties include ethnographic and qualitative research with a focus on urban slum communities, adolescents, and marginalized groups. We should soon have Robert Hakiza, who is joining us from Kampala. He is a refugee from the Democratic Republic of Congo and co-founded and is the executive director of an organization called Young African Refugees for Integral Development, or YARID. It offers refugees a range of opportunities, including vocational skills training, English courses, and seeks to empower refugees, asylum seekers, and other displaced persons. He's a TED Fellow and an Aspen New Voices Fellow. And for myself, I'm a researcher at the Human Settlements Group at the International Institute for Environment and Development in London. I have a PhD in city planning and a master's in social policy. I've worked on health and informal settlements, informal workers, access to shelter, and water and sanitation. Since joining IAD in 2017, I've worked closely with urban grassroots organizations in Kenya, Tanzania, Zimbabwe, and India. So we're delighted to have you with us. If we can just kick off, our first presenter will be Sabina Rashid, and I'm just going to start sharing slides.
Hi, good morning, good afternoon, good evening, whoever's watching from wherever. I'm going to switch off my camera because it's going to be easier in terms of my internet, and then I'll switch it on later if there's any questions. So yes, thank you, Alice, for doing this. So I really want to talk about what risk means in public health and moving beyond sort of the biomedical or the clinical approach to risk. And if you look at the whole COVID crisis, there was particular paradigms or sort of discourses around risk that if you contextualize in different country contexts don't necessarily apply to those who are the most marginalized. So I'm going to talk about adolescents' lives during COVID, but give you a window around what happened in Bangladesh. Okay, next slide. So we have the largest sort of informal slum settlements in the entire country. Dhaka City is the capital, so there's more than 4,500 slum settlements, a lot of migration from rural to urban, often push factors looking for jobs and opportunities. And they set up little homes that eventually mushroom into many, many households, either on private land or government land. So here are some pictures of slum settlements and life in a slum settlement. It varies, it's quite diverse. Next slide. So one of the key concepts I want to talk about is risks and vulnerability. In the Bangladesh context, but in many, many countries, it was a very clinician-led task force approach, where to prevent COVID, you have to wear masks, you have to be in shutdown, you have to wash your hands. And at least in the Bangladesh context, there was a sort of enforcement by surveillance by the army and the police to allow for the shutdown to continue, to ensure people are wearing masks, people are washing their hands. So I'm going to challenge these concepts of risk in public health. One, it's very individual based, it's very biomedical, and it doesn't look at context. What are the social, structural, environmental contexts that many different communities, heterogeneous groups find themselves in, which may not allow them to wear a mask or follow lockdown or the ability to wash their hands? So we need to reframe health beyond a biomedical model. If we look at pandemics, but also future pandemics, we need to really understand the social kind of dimensions and the personal dimensions that impact on health and have adverse effects. Next slide, please, Alice. So I remember being in the office, it was March 26th, 25th, and then the government declared a nationwide holiday. And the holiday was a total lockdown. Everything would be suspended, and schools, businesses, universities, shops, everything was shut. Everything was declared a national sort of lockdown, with the government having the army and the police on the streets. So it just came up. There was a lot of discussions around, we'd hear rumors, but this was just announced in a day. Next. There were a lot of discussions particularly during the peak period globally, but also in Bangladesh between March and June, about the economy, about economic threats. There were a lot of debates in newspaper articles about hunger versus economic communities that are worrying about starvation, job losses, garment factories not being open, restaurants being shut, etc., etc. Next slide. So in general, we have poverty and inequalities in the country. This is pre-COVID. So it's not like COVID suddenly brought about this, but what it did was it magnified and exacerbated the levels of inequalities and poverties amongst the already vulnerable populations. After the national shutdown was declared, as I said, there was a surveillance. It was enforced by the army and the police. And there were many, many reports, research and otherwise, saying that 80% of our workforce, which is the informal sector, were affected, from domestics to female household workers who were no longer employed in jobs they were let go of, sex workers, factory workers, people who pull rickshaws, street hawkers, etc., etc. The garment sector was badly affected if you look at the interconnectedness between the global and the local, because even though orders were made and they were ready, the international factories did not honor their contracts, and they canceled a lot of the orders, which created almost a $3 billion cancellation, which led to even further impacts on factory workers, factory businesses. During this period, amidst a lot of the sort of debates and discussions, the government rolled out some stimulus packages, economic, relief materials and food. There was criticism around the mismanagement, around cash transfers and even relief materials, which were beset by irregularities and politicization. Next slide. Research evidence, we took forward about 23 research assessments, but throughout the country, from civil society, other research institutions, universities, Transparency International, many, many organizations, including journalists, were doing lots of national level surveys, rapid assessments, and we quickly understood that food consumption had reduced. There was fears of starvation. There was worries about no income because it was complete lockdown. You couldn't leave your slums. You couldn't leave your home. A lot of heightened emotional and mental stress in both rural and urban areas, affecting different men and women differently. There was a lot of stigma and misinformation around COVID, a lot of blaming, hiding of symptoms, fears of isolation and quarantine. The language of communication was not socially, culturally explained, and there was eviction of suspected COVID patients from various slums and villages. Our health services was woefully unprepared. Patients were being turned away. It was all over the news. It was showing people dying, and there was a lot of fear during those first 3 months. And the global media had amplified the fears, and Facebook had amplified the fears with the death and dying everywhere. Next slide. So, I mean, this just shows there was a lot of writing then in the journalism, even though there was a law passed that we were going to censor the kind of information, so there's no fear mongering. Journalists continue to write, civil society, us as academics continue to write about poverty and lockdown, and do we need to rethink how we're going to take this forward? Should it be phase by phase, etc., etc. Next slide. There's a picture of a group of people trying to loot a food truck out of desperation in one area. A journalist took a picture, posted all over the news. There was a lot of backlash, a lot of criticism of the government. Next slide. Garment workers were protesting. They said, we need our salaries, we need our jobs back. There was a lot of clash, and it continued. They were just desperate for jobs and opportunities. Next slide. So I'm going to tell you, I mean, we have, Bangladesh is sort of the 8th highest sort of early child marriage amongst the poor. And we have also many young men who are married around 17 or 18. And I'm going to give you a few stories very quickly to give you sort of why we need to unpack health more broadly. And it's not just about disease inside the body. So here are pictures of young adolescents either cooking or working or with a baby to look after their families, married, unmarried. Next slide. Here, young boys, often when the males leave the household, young boys take on jobs, often when there's a lot of poverty, males drop out of school or never go to school because they can't afford it and end up taking on jobs. In the informal sector, often occupational hazardous jobs to manage. Then you see sort of everyday life, but there's a lot of unemployment, a lot of frustration, and particularly in slums, there's also gangs in the absence of any other kind of support. Next slide. Here's a couple of stories, just to give you a sense of the contextualization during the peak between March and June. We're doing a bunch of studies through the ARISE project, where Mina, she was pregnant, her husband was not working. She said he was sick. They couldn't work, they were worried about the lockdown. She didn't know where to go, what to do. Health services were kind of uneven. She didn't have access to ANC and PNC care. She found out through spending much money, borrowing from creditors to find and go and give delivery in a private hospital. There was delays to vaccination for newborns. Nationwide studies found there was delayed vaccinations for newborns. Then there's Mohit, a young man living with a disability. We did a national survey. We followed up these groups. And what we found was because of the lack of mobility and the lack of caregiver who was divided between their responsibilities with COVID, being in complete shutdown, very difficult to access information services on relief. Other young males talked about taking on the male role. They had wives, they had children. They were 19, 20, 21 years old. They were desperate for an income. They went from, having a job in a factory to selling fruit on the street, running away when the police came, hiding from the police, going back on the street, taking lots of loans from credit lenders. Shana is another young woman. She was below 18 years of age. You need to have a national ID card to apply for relief. She couldn't apply for it. And she was a street hawker. So she told me a story of how she went on the streets despite the lockdown, defying the police, pleading with them that, she has children, she's a young mother, and they let her, hawk on the streets. But she said the cars wouldn't stop, and she was just desperate for an income. She walked to 30 households in the richer area looking for a job, but she was turned away because the fear of stigma and contagion was so high that throughout the country, not only just the poorer areas, rich areas were cordoned off if there was a suspected COVID patient. So this brings together the economic, just if you could go back a slide, Alison, I'm wrapping up. If you could I just want to take you to Mina, Mohit, some of the young men and Shana's stories. It gives you sort of the personal, the economic, the social, that all come together that impact on creating stress and lack of vaccination, lack of care, neglect, the ability not to access relief material, nutrition, and the fear and the desperation. So health is much broader in the lived experiences of most vulnerable groups. And so the concepts of risk have to be expanded and recognize these very real contexts of lived experiences. The final two slides are really about Bangladesh has a history of community-based approaches. Some of our most successful public health approaches have been around community-based engagement around oral saline to reduce diarrhea, the TB vaccination where we went from like a certain percentage to about 90% coverage throughout the country. Next slide. I'm almost done. ORS, I mean, there's so many examples during floods, famines. We've always had a very inclusive approach. So my final sort of key points, reflection points are, next slide. that if we look at some of the issues raised by Mohit, Shahana, and Meena, they're not just single voices, but these are stories and narratives and surveys that are found throughout the country, urban, rural, longitudinal. And the point is, as we move forward with COVID, we really need to look at an inclusive, locally led community approach where we brought in community members, religious leaders, drug sellers, different actors. Because if you look at the communication around COVID, there was a huge gap and a disconnect, it was very top down. In December 2020, the government announced a inclusive platform with NGOs and other actors to continue to tackle the economic and some of the other challenges around this unfolding pandemic. My final key points are, it's very important to recognize context, to adopt and borrow shutdown and lockdown from well-off countries, but in Bangladesh, there's no appropriate social safety nets, is risking greater vulnerabilities for the most marginalized. We also need to have a socially just model if we want to address leaving no one behind. If we look at the SDG goals, we really need to recognize the underlying barriers to achieving a comprehensive health for all and a rights-based approach for non-discrimination, accountability, pro-poor, gender-sensitive. As two quotes say, how do you regularly wash your hands if you don't have access to soap or running water, which is the case in many slums, erratic water, it's crowded, it's congested. There is no space for physical distancing. You have families of 7 or 11 living in one small space. And as one garment worker said to us in the interview, we will die by starving before being affected by corona. The government eventually opened up the country in June. We're having a very successful national rollout of a vaccine program. So I have to applaud the government, and they've been extremely aggressive, and it's a free vaccination, very simple process. Thank you very much. Thank you, Alice. I'd like to acknowledge Arise and my project partners. Thank you.
Great. That was wonderful. Thank you so much. I think we will now pass to Abu. Is he still with us? Sorry, it's a little hard for me to see. Abu, actually, it looks like he's lost Wi-Fi. So I might, if possible, Sareka, I think I might just ask you to present next. Oh, sorry. We do have Abu with us. Is that? Apologies, then I will just hand over to Abu. Thank you.
Hello, good morning, everyone. This presentation is basically about understanding the urban governance, water systems, and how they link to health systems generally within the context of Freetown and informal settlements. Now, the presentation I'm going to make, draws its data from the work we did with Institute of Development Studies, IDS, with funding from Economic and Social Research Council. And this data was collected in the pre-COVID period, but a lot of the narratives within this one bear a lot of relevance to the current COVID situation that we have within the country. So the first slides that I'm going to present are going to just present a general narrative of how the public water systems are configured and how they bear relevance to water access within the informal settlements in Freetown and the formal settings generally. So if you look at the slides, you can see that, for example, you have regulatory actors and then you have service actors. So within the regulatory actors, you have the Ministry of Water Resources, which is basically responsible for providing oversight and ensuring that policy regulations are provided. And then there is also the Electricity and Water Regulatory Commission, which was enacted in 2011 as a way of ensuring that there is quality assurance in terms of water provision and ensuring that people comply to quality standards. Because within Freetown, there are a lot of private service providers whose services require to be coordinated very well. And within the service providers, there is the Guma Valley Water Company, which is a private public water utility company. it provides water services basically within Freetown, but its services are mainly limited to formal spaces because within Freetown, there are a lot of challenges in terms of water provision, and one of which is the weak infrastructures that are there. And then within the governance systems and within the service actors, there's the Freetown City Council, which is the municipal local council that is supposed to coordinate provision of water services within Freetown, but regulatory systems and legal systems make it very difficult for the Freetown City Council to coordinate or maybe supervise the main water service provider within Freetown, which is the Guma Valley Water Company. Provision of water was delegated to the Freetown City Council under the 2004 Local Government Act, but there is a challenge. One of the gaps is that the Freetown, the Act provides that water services are provided under the local governments by the Sierra Leone Water Company. But the Sierra Leone Water Company, which is Sawako, only operates within the rural areas. And since Freetown is outside of the rural areas, it does not have much control over how water is provided by the Sierra Leone Water Company. And then because of regulatory or legal gaps, it cannot also control the Guma Valley Water Company because it is a public-private service provider. So because of this, we see that water service provision is challenged in Freetown, and it also has a bearing on how informal settlements residents can have access to water. So the next slides can show you that within Freetown, there are definitely gaps in terms of how water is accessed by people living in formal and informal spaces. And one of which, like I said earlier, is the weak infrastructures, which cannot allow the transfer of water to informal settlements, even where water was available. And then we can also see that informal settlements are largely not connected to the national water grid because of these governance and regulatory challenges. So because of this weakness, we can see that there is a lot of community co-production of water services. But at the same time, while this co-production happens, communities cannot be able to guarantee quality of service because they are not regulated by any national or city level providers. And so in some cases, NGOs intervene to provide these services, but in many cases they are overstretched, so they cannot be able to provide services for all of the communities. So even within the informal settlements, there are differential access gaps. For example, there are some communities that can have more access than others. So in our study, we concentrated on two communities, one of which is called CKG. It's Crabtown, Coletta, and Greybush. It's an abbreviation of some adjacent communities that are very close within the central of Freetown. So within these communities, we can see that there are some that have relatively high access to water, and there are some that have much difficulties. So in CKG, you can see that communities have access to water, but the quality in many cases is compromised because you can see that these are community level services that are produced by communities themselves. So the water that you can see, the well that you can see on my left is, you can see that it's very shallow, and the other one on my right is also not well protected, so quality is an issue. So CKG, like I said earlier, is in the central part of Freetown, and it is very close to one of the largest dump sites. And so these dump sites sometimes, as a result of huge flooding, interfere with the water bodies, which has a tendency of contaminating the water services. So in terms of governance of community water services, we can see that there is, a hybrid governance system, like in CKG, for example, where a government main pipe is controlled by youths who are mainly unemployed, but they take advantage of their buoyance and strength, and then they control the major government water pipe, where people pay little money to collect water. And then there are also some that are privately owned, and there are some that are, tanks, where private individuals buy tanks and then they sell water to community members. And then there are also some public taps, which are paid less for, but distance is very far. So in terms of access to water generally, these are in many cases mediated by a number of factors, and one of which is, influence. Some people have much influence in terms of social status. Some people, because of their age, they are allowed to easily access water, like people who are old and so. And in some cases, for some people, they can defer payments, and they can pay for these services monthly, as the case might be. And then also, access to water is something that creates or deepens, the already vulnerable situations that communities face. So in some cases, when there is a dire need for water, communities can prioritize access to water and then defer access to other household priorities like food and healthcare access. So the other picture you see here is another community in the far east of Freetown where we did our study. It's called Moyiba. It's actually a hillside community, but there are also differences in terms of how the community is spatially organized. For example, there are some parts of the community that are, on the extreme side of the hill, and there are some others that are on the low side. So there are differences in terms of how people access water. So those, right up the hill, topography makes it difficult for them to sink well and so. So because of that, they create their own ways of having access to water. So you can see children digging up a hole just to be able to have access for household utilization. And then this is the lower part of Moyiba, where because of the easy, because of the topography also, it's easy to have access to water. So an NGO contributed to provide water for them. So they have access to this water, and they pay sometimes very little to have access. But because of the growing population within the community, this water service is sometimes very much overwhelmed, and it's difficult for people to have access. So, like I said earlier, the spatial difference is one issue that actually affects access to water. And like in CKG, there's hybrid governance of water systems. Some of them are privately owned, some of them are commercial, and some of them are communal. But one of the biggest things that we found was that, the way community water systems are managed, depends on how much people pay. So there are some that are well managed because people pay for them, and so because of that, they have people who take care of them. But those that people do not pay for, which are free access, they are largely not protected, and quality is compromised. And then one important thing that actually came from our governance scoping of the study was the fact that communities felt that access to water is something that is very challenging because they feel that their elected representatives are not responsive to their needs. So because of that, they find it difficult to have access to water. And then like in CKG, access to water competes with some other growing family priorities like healthcare needs and that kind of thing. So finally, before I round up this presentation, I just want to point out two key points. Because of the fact that people in informal settlements in Freetown have limited access to water and then compromise quality of access, this has very huge implications on their health because in many cases, some of these water services are not protected, and people who do not have money to buy sachet water are forced to drink from these water sources. And then finally, we can see that the differences in access to water is mediated by spatial inequality within Freetown, where the formal areas of the city are concentrated with improved services, whereas the areas that are informal, there's less concentration in terms of how services are provided for them. So this has huge implications for them and on their health. So thank you very much for listening, and hope to listen more. Thank you.
Thank you so much, Abu. That was great. I was hoping to pass to Robert Hakiza if he was able to join. I just spoke to him a minute ago, but if he's not here, we can also just circle back to him in a minute. Robert, are you here? Okay, I'm going to assume he's having Wi-Fi issues, in which case, Sareka, if possible, I might just have you go next, and we can always return to Robert when he's able to join. Is that possible for you to go at this stage, Sareka, please?
Yes, I can. Can you see the slides?
Yes, great. That's perfect.
Thank you, Sabina and Abu, for starting us off. Today, I'm presenting on behalf of the RISE team at the George Institute for Public Global Health, and also much of what we have learned from our colleagues at the RISE Consortium. So the focus of the presentation that I'm going to do is maybe just a little bit away from what Sabina and Abu described. And it sort of moves away from the larger space of informal settlements and focuses on waste-picking communities in India. And through a series of pictures, I want to sort of bring to attention what are the health and social justice issues that we will have to deal with. And we will have to deal with, I will leave it at that. So just a bit of a background, waste-picking communities number, we have no real estimates in the country. There are some estimates that say they're up to at least 4 million people. What they do is they pick, clean, and sort waste, segregate waste, and sell it up the value chain to make a living for very little money. And also, to a great extent, their lives can be characterized as living in perpetual austerity. That is how their lives can be characterized. So to some extent, I think when I was thinking about what do we share when we talk about health and social justice, because that was one of the key themes of this panel, really. So to some extent, I think all of the things on the screen, it is about work, it is about homes, it is about safety, it's about dignity, and it's also about justice. And all of these combine and come together in many different ways if we want to use the lens of justice for communities like the waste-picking communities who are assigned to the margins of cities and societies, both in the social space and through institutions as well. So if we understand justice as fairness and reasonableness, that could then mean that, each person should receive his or her due. And it's also the case where we could make the case that burdens and benefits should be equally shared and distributed across the society. And there is also a requirement that a very powerful minority that exists in our countries accepts their fair share of burden and make efforts to protect the powerless majority who, as I said, in this case, the waste-picking communities, who are like characterized by living in austerity perpetually, and how they deal with the death, disease, disability, and some other things. So now I'll take you through a series of pictures to some extent, which would give all of you an insight into what is the world of waste-picking communities. So when we talk about work, there's a tendency to talk about work as workplaces. And there are images that many of us have in mind. But as you can see on the slide, both of these are the workspaces for waste-picking communities. So they may be working in the dumps, as one of the pictures shows, but they also walk the streets of the cities. And you can see that many of them have to climb these really steep stairs all the way up and down. And this is from the city of Shimla, where we are working, where we are doing our work. Now, I think one of the things when we talk about work is we don't understand the time that people have to spend in order to collect this. So on an average, we have found that most of them get up between 3 and 4 in the morning, start walking the streets and they literally are on their feet walking for 9 hours, bending and picking up things, which mainly plastic, because plastic is what they're able to sell and make money. So this is one of the things. So, and as you can see, when we think of waste, there's normally only plastic that sort of is the most apparent visual that we see across, whether it's popular magazines or anything else. So as you can see, this person is picking up plastic from the drain, but there are also others who pick up wood chips, broken things, and then try and sell it. And they pick up batteries and they pick up all sorts of things to try and sell them. Now, one of the things as you can see, they have to carry a fairly heavy load, sometimes weighing up to 70 kilos on their backs as they walk through the streets and pick things up. And this is one of the reasons why even the few studies that we have about occupational health issues or waste-picking communities is about musculoskeletal problems that they face. And because they just literally have to do this, carrying this weight and walking day in and day out. And now I just want, this particular slide basically shows that there is no distinction between a workplace and a home for most of these waste-picking communities. It is rare to come across them as living in what is known as pakka or solid houses. Most of them live, as you can see, either in those small tents, or they just collect whatever scrap they can and try and build it. You can see that the babies are sleeping when the mother's possibly picking up plastic and waste from the dump yard in one of the photographs. And this is from a place called Guntur, and where we're working with a group there who live next to the dump yard there. On the right, you can see there are plastic bins. Now, those bins are actually fairly expensive to get, and that is where they store their water, and sometimes even store their plastic and other things that they collect as well. Most of these people live in conditions where there is no water supply, there is no electricity. So a lot of, and why is this important? Because a lot of the messaging that happened, for example, in COVID was through social media, through phone apps, and through other things. Whereas these communities, there's a huge deficit of even having mobile phones among them. And then they tend to live very far away from any of the health services as well. So what we did find was that most of them actually aspire to have carts like this so that it makes it easier for them to pull the load if they can. But then there are no loans available for them to buy these. And if they want to do, they get indebted to from whomever they take, which they take many, many years to pay back. But this remains an aspiration that even if they could simply just get one of these things to pull the thing, it would be easier on them in terms of, and if it's, if it's mechanized or motorized, it's much better for them. So this is this remains one of the most aspirational things they want when they talk to us. So now in this slide, what I'm showing is that there are certain issues that can be done for them, but they don't get done. As you can see, the two women, they have these sort of bright yellow gloves. So one of the things is that gloves are supplied to sanitation workers, but they're not fit for purpose. And the glove size is of an average male hand. And so most of the time what happens is having gloves to protect them from cuts and other things that they might pick up, they don't use because it's not practical and they're unable to. But it seems there's a certain kind of inertia of actually systems responding and adapting to give fit for purpose gloves to them. And then you can see that there's a person there who's wrapped his feet, his shoes in plastic. This is done when they don't have access to gumboots, which is required if it's in the hilly region, for example. But also, this is the only way they can protect their shoes, and shoes are expensive to buy. So this is how they go about doing these things. Then you can see a lady's hand. So during the COVID time, a lot of the workers they had to keep cleaning their hands. And so there were cuts, there was burning, there were lots of things. So in the rush for protection and washing hands properly, some of the things that don't get considered are this. And especially if this is going to happen in wintertime, in the hills, it can be a huge, huge problem for the workers. So this slide basically shows that they work with their hands. They pick up syringes, used syringes, because it's plastic and it has value, it can get sold. And then you can see that they're dismantling batteries, they're dismantling other things just by hand. And they get exposed to really toxic chemicals. But essentially, because a lot of the people who work in the waste world are in the informal, what is known as the informal sector, there are no regulations, there is no accountability of the state towards them. There is nothing in place to say that they should not be exposed to these kinds of things. Are there better systems through which you reduce the toxicity exposure for the communities? None of this is on the table or on the cards when it comes to things. So I think this, to some extent, this goes back to what I started with. When we talk about justice as fairness, and we talk about fair distribution of primary goods, equality of opportunity, and that you have to have the allocation of primary goods to the people in a fair manner with, investment in nutrition programs, childhood development, improving quality of work environments, trying to reduce income inequality, trying to engender political fairness, and in the Indian case, caste discrimination and caste othering as well. But as you can see, while we talk about justice and while we're talking, how do you actually do this with communities like this who remain on the margins and the deficits are so steep when you work with them? Now, the next slide, I just wanted to put this. And this is particularly specific about the health systems. Over the last year and a half, in different forms, we have heard people from within the health services and broadly the health system talking about waste-picking communities as parasites. And so to that extent, if we think that health systems are social systems, then they are also embedded with prejudices, people who are in there. They also act out these prejudices and practice them. You other them. And so to what extent would a health system actually be capable and willing to build trust with marginalized communities like the waste pickers to make them feel welcome? So an example that I can share is that there's a group of 45 families with whom we are working in one of the dump yards in Guntur, which I showed a picture about. In the last 2 decades, there's not been a single birth at a health facility there. They are very scared. They don't want to go. They feel they would be ill-treated. Their experiences have not been good earlier. So it took months of intervening by our grassroots partners to build confidence in one woman who was pregnant and to help her go to the health service and deliver her baby, which she did finally. But what I'm trying to emphasize is that just simply talking about responsive health systems and social justice in health systems, it's not going to happen unless there is some sort of thinking within the broader health systems and people who are part of it, including researchers, policy makers, service providers, whoever is, how do you deal with something like this? And I think if we agree that the dream of public health is of minimizing preventable death and disability, which is also the dream of social justice, I think as if we think that is what it is, then the social justice framework could offer at least a powerful critique of existing health systems, which could be constructive, from which we can learn. So I think the health systems remains very far off for these communities. And essentially, this is one of the most difficult aspects of the work that we are trying to do with Arise. So the idea that anything in the HPSR world and public health is not just a technical activity, but as something you see it as a means of doing justice and asserting the value of human life. I think it's only when we start doing that possibly we can see some movement towards social justice for communities like this from the health systems. So I will end with this slide. Initially, I thought I would show a closer body of one of the waste pickers to emphasize the impact of how they live, how they work, how they're treated, the inability to access services, constantly being seen as somehow being valued less than human in across most of the institutional spaces. It does damage their bodies and their minds. And if we're going to talk about health and well-being, I think currently the picture that is on is fairly common, you can see, but it is somehow we still seem to look at these communities from a distance. there seems to be an unwillingness. So they're seen as the last mile. We hear a lot about the last mile. I wonder whether if they become the first mile, the health systems would look different. I think that is something. And then you move away from emphasis on individual responsibilities, move away from victim blaming, and sort of encouraging and being responsive enough to build a collective endeavor so that health and social justice can be attained for these particular communities. I will end with that. So thank you, and thank you for listening.
That was fantastic and really thought-provoking and very moving. Thank you so much, Saraka. We would like to move to Robert Hakiza if he's able to present on his work with refugees in Kampala. Robert, are you able to share your slides? I'll just give him a minute. He said he's with us. I'm not sure if there's a connectivity issue though. Just give him another second, but I can always go and loop back to Robert. I think he must have just dropped off. In that case, I'll just step in for the time being and share my slides. As mentioned, I'm a researcher at IIED in London, and I'll talk today about understanding multiple health risks and the role of community-led data collection in informal settlements with a focus on Nairobi, where I've been able to partner with Slum Dwellers International Kenya, and look forward to sharing this with you. Residents of informal settlements, as we know, typically face several health risks and exclusions at the same time. But I also want to briefly note that these areas can offer significant benefits to residents, and these assets should be built upon. I'll briefly discuss the complex drivers of informal settlements growth and the need to understand variations between and within informal settlements. And finally, I'll discuss how community-led data collection can help to reveal multiple risks with additional potential to foster responsive governance and help to amplify residents' voices. Just as a starter, and I can't do justice to all of the richness and such as community organizations and other assets in informal settlements, but I wanted to note that housing is often better located or more affordable than formal units. There are often vibrant livelihoods in the settlement, such as food vendors that may sell to fellow residents, as you see here in Nairobi, or provide access to jobs nearby. Settlements may have a strong sense of community and active social or religious organizations that have been vital, especially in the context of crises like COVID. And residents may sometimes feel pride as their homes are consolidated or as they're able to successfully advocate for services and other improvements. And of course, there are many drivers to informal settlements growth that may include historical factors that could date back to colonial era or post-independence, elitist planning. It may reflect a combination of household poverty and lack of access to affordable housing finance, as well as exclusionary planning, population growth, economic pressures or stagnation, and perhaps most importantly, the role of local governance. And as we know, and we've seen in these other presentations, the quality and capacity of local government, as well as income levels and distribution, can critically influence urban health outcomes. Just as a quick overview, I'm sure the others presentations have touched on this already, but residents of informal settlements face a wide array of risks, often at the same time, linked to hazardous shelter and local environments, tenure insecurity, minimal access to infrastructure, food insecurity, as we've seen, especially in the context of COVID, exclusion from high quality healthcare, education, refuse collection, violence and insecurity, and disasters and climate change. There are often a wide array of social, economic, and political exclusions, including the risk of forced evictions. And it's important to note that informal settlements can vary widely and change rapidly, but we rarely have access to the kind of in-depth data that we would need to understand these changes and multiple risks. Just to use a few images from Nairobi, the settlements in many informal areas have been low quality, low-rise shacks, as you'll see on the left. But increasingly, there's a shift from shacks to multi-story units or even tenements, as you'll see on the right. And you might also see here just the extremely low quality of water provision. Sorry for that. Which is called locally spaghetti water pipes that pass through open drains and uncollected refuse, which can then promote cholera and other disease outbreaks, especially during the rainy season. And just as a contrast on the right, in the lower hand side, you see a much more low density peripheral area of Nairobi that's still urbanizing and often without services. So just to capture the transformations and an array of types of informality even within one city. And just to note, there's also a need for multi-level analysis of risks, both at the household and settlement levels. We've seen in other presentations already that settlements can be located on hazardous sites like floodplains, riparian reserves prone to landslides, or enterprises that may again pose major health risks. But when we only look at the household level and say UN habitats definitions, we'd miss these wider contextual factors, and area-based measures may help to understand slums' health challenges a bit better. In terms of data gaps, we know that there are roughly 1 billion people living in informal settlements according to UN data, but they're often invisible in census or other official findings. Data collection and improved service delivery, of course, is not a political priority in many informal settlements, given that these areas may be disenfranchised or voiceless or only occasional vote banks. Government capacity constraints, as well as logistical challenges or insecurity, may hamper data collection, even if this does become a priority. And there's a need to recognize that visibility can be quite double-edged, so that in cases of settlements, say in prime locations, greater visibility may only lead to heightened eviction threats, and may also disrupt the status quo, say, for informal service providers who profit from minimal provision and may therefore block any attempts to improve slums shelter and services. So into this gap, the global network called Slum Dwellers International, or SDI, has played a key role in improving data collection in informal settlements. It's a network of community-based organizations across Asia, Africa, and Latin America. And one of their key strengths has been use of community-based data collections, I'll discuss, which has several possibilities to enhance health and inform equitable initiatives. Data collection can help to prevent evictions and enhance visibility of, say, of settlements at high risk of eviction. Can be used to document everyday risks, shortfalls in services and infrastructure, and past disasters in informal settlements. These can then help to identify key priorities for upgrading or other initiatives. And more fundamentally, by helping to put settlements on the map, these findings can help to transform attitudes and misconceptions within government, and thereby lead to more responsive governance, to help identify beneficiaries and entitlements in case of settlements do needing to relocate. And more broadly, it can also help to foster residents' empowerment, mobilization, and social cohesion, thanks to gathering their own data. So just to quickly show this process, which I can't do justice to, but this is a few set of images from Kisumu in Western Kenya, where in the context of doing a household enumeration, each structure will be numbered and put on a community map. Local mobilizers will then collect data and quality check the questionnaires before posting the findings in a public space so that they can be verified and discussed. To take just a few examples from Kisumu as well, an enumeration of 70,000 households and subsequently profiled 28 informal settlements, where they found that 49% of the city's population lived in informal settlements. Of these, 83% were living in temporary structures, 78% in dangerous sites such as prone to flooding, and 69% lacked regular water supplies. Half of these settlements are actually over 60 years old, so while the structures may be temporary, the settlements were extremely lengthy in their histories. And importantly, the data also captured a range of community groups, schools, local businesses, and other assets. In the Kenyan context, the Slum Dweller Federation, Muungano wa Wanavijiji, has been able to do data collection at scale, including working with county governments and profiling slums in 5 different counties, including Nairobi. And so, as we've seen just in this brief snapshot, grassroots data can help to reveal multiple risks and bring attention to marginalized settlements, helping to fill data gaps and bring new issues to light. These can then create the foundation for partnerships with local government utilities and our donor agencies. These methods of organization can foster community empowerment and gender equality, as it's often women leaders at the settlement level who gain in confidence and increased recognition as leaders. In turn, there's a strong possibility that over time, data can spark locally appropriate interventions and foster more responsive governance with linked potential to support social inclusion and other social determinants of health. And if we have time, I wanted to also note that many members of SDI have told their own stories using grassroots media. So I wanted to just briefly share a video from one informal settlement in Nairobi called Mukuru, where residents have been able to explain some of their challenges, and ultimately this led to actually the county government declaring an upgrading area. But just to see a little bit from Mukuru, I'll share with you now.
Sanitation and poor drainage has been a major problem for the residents of Mukuru for more than 10 years. 75%
Alice, we can't see the video.
Oh,
We just see your presentation.
Oh,
Do you want to put
sorry.
the video? Yeah,
Yes,
because
I
that'll help.
thought I was. Apologies.
No.
Let me try
Oh,
again.
unless it's my internet. Yeah.
Let me try again. I
Thank
probably
you.
was still showing the wrong one. Let me try. Thank you. Are you able to see it now?
Yes, yes, yes.
Good.
Sanitation and poor drainage has been a major problem for the residents of Mukuru for more than 10 years. 75% of the population get affected yearly. This is due to lack of proper sewer lines and proper disposal of waste, which causes several diseases like cholera, malaria, typhoid, and other dangerous infectious diseases. Women and children are the most affected people. This is what the people of Mukuru had to say about this.
Kwa majina mimi naitwa Peter Mwangi, mkaaji wa hapa kwa Ruben. Nimekaa hapa tangu 1976 mpaka sasa. Mimi hufanya biashara ya kuuza choo ambazo tunatumia maji, na kuna wakati mwingine huwa zinaleta shida sana. Tunakosa mpaka mahali pa kukaa. Hata inatubidi wakati mwingine tunaenda kwa majirani. Hiyo ndio ile changamoto kubwa tunakuwa nayo. Na
kwa majina naitwa Anno Demba, mkaaji wa Sinai. Upande ya drainage, kitu naweza kuongelelea ni kwamba ile drainage ambayo tuko nayo zimezibika, na ndio watu wanatupa takataka, na zile choo watu wanaenda kwa makaratasi usiku bado wanaendelea kutupa pale.
Dhamini wanaweza patikana watuwekee hizi za biogas, kitu ambacho kitaweza kusaidia community. Inaweza kuwa mzuri zaidi, kwa sababu hiyo watu wanaweza kuwa wanaitumia kwa kupika, wanatumia kwa mwangaza, na haina madhara yoyote, na upande wa environment itakuwa maridadi.
This problem has remained years and years, but we can change the situation. To know more about real life story at grassroots level, subscribe to our YouTube channel, K.
For your attention, and sorry for not being able to share this earlier. I think that this just was a way to capture some of the voices from community residents, and also to emphasize that this is one of the settlements where actually community data did help to encourage the county government to intervene. So we see it as an important example of community-led data leading to the kind of partnerships that could improve health and well-being. I think at this point, we would just want to start discussions. I'm thinking that Robert isn't able to join us, unfortunately. So at this stage, we've gotten already one question for Abu around the gender aspects of water provision, and we've kind of touched on it in other presentations, but perhaps we could just discuss a little bit in the Sierra Leone context how gender inequalities, I assume, intersect with difficulties in accessing water. Would you be able to take that one as a start, Abu?
Alice, is there a question you're kind of
Oh,
sharing
sorry.
with us?
Yes. So from the
That would help
chat.
Abu to respond. Yeah.
Yes, from the chat. We've just gotten a question from Kate asking if Abu can say more about how gender affects access to water in informal settlements. If that's possible, just to tell a little bit how I guess women and girls might be especially affected by the lack of water access. Or any other comments you'd like to share on that. Thank you.
No, what's the question, please?
How gender affects access to water. So are there aspects around, say, women and girls perhaps having particular challenges in accessing water, or other maybe people with disabilities, other kind of vulnerable groups, and how that may affect their access to water?
So gender is one of the key determinants, in terms of access to water. Like the photo you saw there, most of the people that are in the photos are either women or girls. So, and within households, it is mostly women or girls who are responsible for, so they are the ones who are likely to face different forms of vulnerabilities. They are the ones who, because some women are breadwinners, they are the ones who bear the responsibility of fetching water, or who bear the responsibility of compromising other family members just to pay for water services. So gender is a key issue, in accessing water. Thank you.
Thank you so much. Sorry, I was just checking to see whether Robert was able to join us. It sounds like he might be in a different session somehow because I don't see him here. Unless Robert is here, apologies.
I don't think he is. I don't know.
Yes,
Maybe he
I think
can't connect. And his brother was unwell, so who knows? With COVID, there's always emergencies.
Yes.
Yeah.
Maybe just a broader question. I wondered if we could return to the importance of intersectoral action and working beyond the health sector. And if there are reflections from the other panelists around how that might be taken forward, or any examples that you've seen of how that might work in practice. Of course, we've seen in many instances that health inequalities have so many complex roots, and tackling them goes beyond one sector. But I don't know if Sabina maybe wants to start off on that.
No, I was just kind of thinking out aloud, because often, I mean, I've been working in Bangladesh for a long time, and if you just work within the health framework, what happens is, particularly during COVID now, when the government is rolling out stimulus packages, there's a lot of discussions about economic stimulus, the food, the starvation, but in general for people who are vulnerable and marginalized, if you look at the waste pickers, if you look at Abu's presentation or yours, Alice, I think it's very important to see if there's any synergy across sectors to avoid, first of all, duplication, replication, but also to have a much more comprehensive approach to addressing what the vulnerabilities are. Because to kind of have a siloed approach and say, okay, the health ministry is going to do this, or NGOs are going to do this, without any discussions across the other factors that can actually impact on health. That if you see the pictures of the video that you just shared, there's no drainage. There's no space for waste collection. That's like many slums in Dhaka city. If you look at the lives of waste pickers, environment, infrastructure is something that comes to mind. So it really kind of, it's pretty obvious why there needs to be a cross-sectors approach to improve health and lives of the most vulnerable. If that, I don't know if that answers it, but I was thinking infrastructure, investment, water spaces, the kind of the deprivations. It's not just about having the health clinic. And I think the videos, Sureka's pictures, some of mine and Abu's really, really amplifies what those points are. Thank you.
That's perfect.
Who wants to add, or anyone else?
Feel free to jump in, Sureka or Abu, if you're.
Drawing from Sabina's comments she just made, I think within the Sierra Leone public sector, there's the challenge that public institutions really work in a very siloed fashion, And so it's difficult to really understand what happens across sectors and how, they can synergize, some actions, at different levels. And then there's also the big challenge of denial that, the issue of informal settlements is a reality. Public sector policymakers seem to not accept that informal settlement situation is something that they can accept and they can address. So as a result of that, sometimes they just glide over it and the issues keep coming and facing them, head on. So if there's an integrated approach and then understand that this is a challenge and we can address it together, I think it can be much better. Thank you.
Just to give Sareka a chance as well, would you want to share any thoughts on this?
Yeah, hi. Thanks, Alice, Sabine, and Abu. I think, yes, there needs to be, if not even intersectoral working, which is very rare. I think it's the way the institutions are structured. Their goals tend to be very different. So I wonder if the movement is towards thinking more people-centered, and so then that would mean that you will have to bring a lot of different types of stakeholders or different type of institutional strengths to help communities, for example, like waste-picking communities or those who live in informal settlements. But I think my thing is that the health systems, and which is largely morphs into simply health services, is an issue. I think if the thinking in terms of health systems broadens it, then there would be some effort that can go into thinking about, so how do we then network? How do we pull this together? How do we advocate? There are so many things that can happen, but it is how we position ourselves. I think that remains, I think that is crucial for me. At least that's what I feel. Thanks.
Thank you. We've gotten a few questions in the chat, so I'll share those in a second. But just to briefly check again if we have Robert with us. He says
so Robert's indicated Alice he's here,
yes,
but I just
don't
see him. He's in the wrong session.
Yeah, I'm afraid if the conference moderator can maybe just direct him. We would love to have him join. I just think there must be some issue because he's not showing up. So we're very sorry to keep missing him.
Left?
I think so. We have 15 more minutes. We're meant to run for another half.
Great.
Half past. So we've gotten some questions. One for Sabina around the vaccine rollout process in Bangladesh and the models and approaches used. Maybe we could just have her answer that. And then there's a question to all of us.
So whoever's asked that, I didn't know what to expect living and working in Bangladesh with the COVID and us, adopting certain approaches that was very difficult for particularly the poorest. But I have to say that the government has been extremely successful. And compared to 130 countries that have not even rolled it out, we've actually rolled it out. There's a couple of million have already been vaccinated. Very easy SMS approach, vaccine booths, volunteers throughout the country. You've got people from all kinds of socioeconomic backgrounds, from the poor to well-off, lining up through an SMS registration process and getting vaccinated. I think the model approach is the government has been extremely aggressive about the vaccine approach. It's been really, really pushing the agenda of you need a vaccine. What I would suggest is more cultural communication around the vaccine, because there's vaccine hesitancy, not just in Bangladesh, but Hong Kong, where I heard, I'm working on another project, 2/3 of the people didn't show up for their vaccine because it's coming from China. Then I had in another country, there's a lot of kind of distrust or worries about the side effects. So I think it'd be important if the government starts investing, and they may, when they're particularly working in the villages and other spaces. But community health workers from BRAC, the NGO, talk about, households asking about how do we register, and it's quite simple. And a majority of our population have phones. So the model is very simple. There's strong political commitment. It's free. It's all over the news, online, and there's service booths everywhere. And you can go up and ask questions. I have to say, living and working in Bangladesh since '93, I'm actually very, very impressed with the initiative. And not a cent, no mismanagement, no corruption. I've got my dates for my next one in April, and so far all good. So I really have to congratulate our government for doing a great job. Yeah.
Very encouraging. Thank you. Our other question, which is very useful, has asked us, I think, for us all to weigh in on how there might be ways to further strengthen agency and capacity of people within informal settlements to advocate for change, or maybe collective approaches as well as individual ways of encouraging action and advocacy within informal settlements. Have there been ways that that's been taken forward in our respective contexts? I don't know if, Sureka, there have been maybe cooperatives or other examples of working with waste pickers that you might be able to share around how they've advanced their voice perhaps a bit.
Yeah, yes, Alice. I think there are certainly efforts to. There have been civil society organizations that have come together, and some of them do have waste pickers as members of their organizations. So, and for advocating for their rights, but a lot of that still remains restricted to. Them being rightful part of the solid waste management system, and a right to be recognized as workers, at least, which they are currently not. So that is happening in the sense that there are people advocating for that. But I think it's more complicated in terms of, I think while we do want the waste picking communities to use their own agencies and come together, and I think we should also, as a group, we are aware that it comes at a huge cost to them. They are time poor, they are asset poor, they barely make a living, they have to do multiple jobs. So what does a collective actually mean in this context is something we are struggling with. We don't have an answer to that. There is certainly an interest. So one of the ways in Arise we're doing is that and in some ways as part of our research team, we do have co-researchers from the community who can't read and write. So it is challenging us in terms of how we do the research. So, so in some ways, if we want to center their voices in our work and advocate for them, then this is one of the ways we are trying. It's a huge ask. It's also making us come to terms with our own power and prejudices and how we deal with some of these things. But also, I think maybe a broader definition of health would be very useful, which I think Sabina did mention in her presentation, where she made the case that we need to move away from the biomedical model. I think that it is very important, and it has to be at the center of any kind of collectivization around health. I think health has remained a very, how to put it, in communities, it's very hard to gain traction on this because, like Abu said, water is a huge issue. You can't live. There are so many other things they're fighting just to get by day to day. And so that is what I meant when I said that if we think of these groups as the first mile, would we plan differently? Would we do and allow for collective agency to build among them? Because I think there has to be some role the institutions have to play in that. Otherwise, it becomes more adversarial in terms of any dialogue or anything. So one party is saying we're doing what we can, and the other party says, no, but you're not doing it. So whether there's a different model that we could think of is something to think, at least. So I have no answers, but I'm just sharing what I think. Thanks.
I was going to just add, like, we talked about social justice, and once COVID goes, there's going to be other forms of, whether you're talking about a pandemic, an earthquake, a famine, floods, other forms of crisis. And until we acknowledge that health at a biomedical model disconnected from context, lived experiences, really does a disservice, because you're spending so much money doing siloed interventions, but we're not addressing the root causes of poverty and ill health and other factors that are interrelated. And I really think COVID actually allows us to kind of critically challenge these existing paradigms that really need to be removed. I would say removed. Otherwise, the issues of social injustice continue before COVID, during COVID, after COVID. So there's sort of Band-Aid siloed solutions. I'm not saying not having a clinic, as Surika was saying, is not important, but it's just one part of the puzzle. And I really think we recognize the root causes of disadvantage, bad health, lack of opportunities, not having food. It's not rocket science. I think we need to just address it in different levels of the global discourse, national level discourse, because it's about political will. Globally, locally, we need to move beyond our disciplines and agendas. That's what I think.
Thank you. I'm actually just going to switch gears if I can, because we do have Robert with us. So while I'm grateful for everyone's discussions, I think we should just give Robert the floor. Are you okay to start sharing, Robert? Or shall I share for you? And thank you so much for your patience. I know we were having some challenges. Robert, are you able to share your screen?
Yes. I'm sorry. I couldn't find anyone apart from the name of Alice. So, oh my God, what is going on? So let me try to share my screen here and then. Hello. Hello.
Yes, we can hear you, Robert. I can share the screen if you want. Is that easier? Oh, you've got it. Okay.
Yeah, let me just.
Should just be on the PowerPoint down there.
Robert, you have to stop sharing your screen at a moment and share again the correct screen.
Okay.
That's all good. Take your time. You have a bit of time. Don't worry.
I'm happy. I have your slides, Robert. Maybe it's easiest if I share. You can just tell me when to change them.
Yeah, please do that, because I think I have.
No, it's fine. Don't worry. I'll just start it here. Is that coming through?
Yes, thank you so much, Alice.
Okay,
yeah, this technology sometimes is
no
complicated.
worries.
Yes, yes, thanks so much for having me, and I'm sorry again for joining late because the confusion I had. So in my presentation, I'm going to talk about how displaced people in Kampala access health services. And this is actually was picked from the research that reads, and it was a British Academy funded project that was we did with the International Institute for Environment and Development in looking into the challenges that refugees in Kampala have in accessing the health facilities. So as you may know, as per the Uganda policy, refugees in Uganda are allowed to join the public health facilities as per the agreement with Uganda government, and also UNHCR, the UN Refugee Agency. And when I talk about the health facilities, we are looking at all these public and or government-funded health facilities, and we have a number of them here in Kampala. Like we have the referral one, the head one, which is Mulago Hospital, and also in each division we have the Kampala City Authority that has at least a clinic in each division. So, and refugees, based on where they are located, they are free to join these health facilities. Next, Alice. So, as you know, when you come to Uganda, and especially here in Kampala, but it's generally in Uganda, so you have to get started with this refugee eligibility system. And in Kampala, refugees are asked to go first to, there is a police, it's at Old Kampala, a place called Old Kampala. It's the only police station where refugees need to report, because that police station works hand in hand with the Ministry of the Office of Prime Minister in charge of refugees. So that's the starting point. So refugees go there. So you have a short interview, and then they ask you some few questions, the reason why you've left, and then they send you, after giving you a yellow card that allow you to go and access the OPM offices, where they are going to now to plan to give you an appointment to come and have a proper interview. And sometimes this process take quite long, depending on the number of people that they have to deal with. So at the end of the day, when the Refugee Eligibility Committee accepts that you're going to be granted refugee status, so you are given this, I've just put this card here, this card. So when you have this card, it shows that you are now a refugee in Uganda. So it allows you, you know, to access, like you can access these health facilities, you can go access the bank and the other services that are around, which some people who do not have, cannot, like asylum seekers. Like sometimes you have asylum seekers who can wait up to more than 1 year when they have not yet received this refugee status, and it makes sometimes, in most cases, them difficult to access the services because they are not yet recognized as refugees. Next, Alice. So here it's see this beautiful picture here. I just decided to put it here to show this Mulago Hospital. So if refugees go, they have to start from the nearest public clinic, this KCCA that I spoke about. And then if the doctor finds it very needed, they can refer you to Mulago Hospital. So next, Alice. So, and here you have a picture. It's not so clear, I'm sorry, but this is a picture of how it looks like at the KCCA level clinics. So as I said, we have at least one in each division. Here you can see people waiting to see the doctor. Next. So now let me a little bit talk about the refugees' life in Kampala. As you can see, these pictures here. This is a picture that we took in one of the slums. Here it's Katwe. Katwe is one of the slums in Kampala here. And we have so many other slums whereby refugees reside. And the reason why refugees stay here, because it's where they can afford, it is where they can get these cheaper houses to rent. But unfortunately, as you can see on this picture, many of these places actually are slums, and in most places here in Kampala, it's a swamp. So you can see the environment, the hygiene, and so on. It's really very bad in the way that it can keep the people living in this environment healthy. And this is just an example. But we have, for instance, in the next picture, Alice, this other picture here, you can see, for instance, that is, we call it the Muongo slum, and we have a very big number of refugees living here. You can see yourself the environment, and when it comes and how such environments can affect people's health, and especially the people living in those areas. So most of the refugees live in these places, and of course, as you know, it's quite very difficult for them, because they not only the environment, the hygiene, but also the nutrition. It's still very poor, because in Kampala here, refugees are expected to cater for themselves. So they have the right to live in urban area. They are given the right to join these public services. They are given the right to join the health and the education facilities. But in reality, sometimes you'll see that even when the doors are open, it's a little bit challenging, because actually that's most of case for us. We talk about free but not free. But for instance, as moving to the challenges, we're going to see refugees, once they go to these health facilities, you'll find, first of all, the language barrier is a problem. So most of the refugees here in Kampala, we find some of them coming from French-speaking countries, and when they come here, especially those who are still new arrivals, who cannot speak the language, they find it very difficult to speak either Luganda and English. And the system in place, the UNHCR and also the implementing partners, they don't really have enough interpreters that they can allocate to all these health facilities in the way that they can be supporting the refugees in interpreting. We talk to the doctor. As you know, if the doctor does not understand very well what's your problems, then that means the treatment also will be poor. And on top of the language barrier, we're going to find that in most of these government clinics and health facilities, there is too much corruption, because the services actually are supposed to be for free, and this attracts many people coming there. Some people have to wake up early in the morning so that they can be able to see the doctor, or if you come late, you have to line up. Sometimes you spend a day without seeing the doctor, depending on the number of people that are there. And this creates an environment whereby we have some people around who ask for money. They ask for money, and so that they can put you at the floor, at the first of the front, so that you see the doctor on time. And sometimes you see refugees who are already vulnerable, they don't have money. It becomes a little bit difficult for them to get money, to give to these corrupt people around, so that they can see the doctor. So the corruption is also affecting. And on top of that, even after you've seen the doctor, yes, the doctor is going, at the end of the day, they will give you a prescription. So that which prescription you're supposed to take to the pharmacy, which is in the same at the hospital. And once you go there, you find that most of these medicine that are needed, they are not available. Or sometimes people are asked, are told behind that if you want to get this, you need to pay money, and this actually becomes a problem. As refugees, the UNHCR implementing partners always say, if you go to the hospital and you are given a prescription and you can't get the medicine, you need to come to the office. And right now we have an implementing partner specifically that is working on health supporting UNHCR. So once refugees go there, that's again a very long process. Sometimes they are only able to provide these painkillers, and when it comes to this medicine that's a little bit costly, they don't provide. And even if you are lucky enough to be promised that you get it, you have to wait. Sometimes 1 week, 2 weeks, depending on as they are navigating in their system. And we've seen so many times people even dying before they get this medicine. And actually, right now, completely, especially since the COVID-19 situation, they have announced clearly that they don't have support to support urban refugees when it comes to the health medicine and so on. So this actually worsened the situation of already these very vulnerable people, refugees living in an urban area. So now, how do we move from this? And again, as we said, I think one of the other challenges that I think I will be happy to talk about. And when you look at the planning, when the government itself plan for these health facilities, and especially at the local level. You're going to see that in most cases, refugees are not included, or just these health facilities at division level are not given enough resources and support so that they can be able to provide all the necessary, because sometimes you find refugees are told that, this is just a favor that we're giving you, but it is not, you are not our priority because you are supposed to be catered for maybe by UNHCR and others. So you see that there is a limited support and the resources, at this division level to be able to support the refugees. And another challenge, we're going to see that there is a problem of proper coordination when it comes to the humanitarians that are involved, in supporting refugee, in providing humanitarian services in urban area. So everyone does what they want, where they want. There is not really a very proper coordination. Of course, we've seen recently something coming up whereby people, these actors started coming together, to discuss about how they can do, but there's still a very big gap, so that, we can see at least everyone filling the gap where specifically where they are located. It is still affecting so many people, and especially the refugees here when it comes to accessing these services. So the solution, as I'm concluding, I think this will be, as I said, the UNHCR, I think, with the implementing partners, I think, because that is a very first point, they need to make sure that they provide enough and as many as possible interpreters at these health facilities, so that whenever the refugees, especially those who are not able to express themselves in the language that the doctor can understand, they get support and to be more comfortable in explaining to the doctor in the language they understand, so that they can get the proper treatment. And I think also we need also to see the UNHCR implementing partners improving their services when it comes, and they consider that, of course, when it comes to the health issues, people cannot wait. You cannot tell a disease to wait for you as you're waiting for the medicine. So people are dying because they are waiting. There's no quick response. I think there is a very strong need of improvement from their side, so that they make sure that whenever people go to them, they get support they need, so that they get healed. And also, I think something that's also need to, on the side of the government, I think there is they need to urgently think of harmonizing, and then also to provide more support to these health facilities, especially at the division level, because the situation in Kampala is that everything is centralized at the Ministry of Interior, in charge of refugee level. When it comes to the division level, and especially when people talk about the refugee issues, there is no a lot that is discussed is there when it comes to the refugee. I think they need to make sure that refugees are included, as they always say, in their plan. For instance, when they supply medicine to the division level, they need also to consider that, of course, because I'm sure they have the statistics, like how many refugees are in that division, so that they can be included in the planning, so that by the time they go, they are also considered as part of the people who are supposed to receive support. I think with this, and of course, without wasting too much time, I thank you so much, and please, I'm happy and open to respond to any question that may come. Thank you so much, Alice, for your support. Bye.
That was brilliant. Thank you so much, Robert. I know we rushed you a little bit, but that was really just so thoughtful and thorough. Thank you. I think we are technically out of time. I don't know how much flexibility there is. If anyone wants to jump in with a question for Robert, I'd be delighted, but I also recognize we might need to close at this stage. I'm sure we can stay in touch with anyone that wishes to follow up with us. It's probably just for me to say thank you to everyone for your time and interest, and we really enjoyed hearing everyone's perspectives and really complimentary and insightful presentations. So thank you all so much. I think for the time being,
Thank you, Alice.
should stop.
Thank you, Alice. Thanks, colleagues. I learned a lot. So thank you very much.
Everyone. Thanks, everyone. It was good.
Thank you.
Stay well.
Join us.
Thank you, Alice. Thank you, everyone.
Thank you so much. Thank you.
Yeah, bye.
Stay well.
Bye.